Thank you so much, Alma, for doing that. Before I introduce our speakers, I'm just going to give an outline of what our speakers are going to be talking about today, and then I'll go into who they are, and from there, we'll sort of take it on. I think then they'll start with their presentation. So today we have our talk is titled Interprofessional Trans Healthcare Model. Both of our speakers are from WITS RHI, and the WITS RHI Key Populations program provides healthcare to trans and gender diverse communities based on an interdisciplinary model of care. Within their teams, they have trans agents, also known as peer educators, community healthcare workers, nurses, social workers, and psychologists. The model that they're using locates the transgender individual at the center of a complementary package of clinical, psychological, and social services provided through peer-led community outreach engagements, fixed clinics, and community-based service providers. The interdisciplinary model allows for a holistic and client participatory approach in all of the services provided at their clinics. Presenting to us or talking to us today, two speakers, Rutendo Bothma and Dr. Tammy Nash. Rutendo is a qualified pharmacist with a master's degree in public health. She has over 10 years working experience in the public health space, specifically in pediatrics, oncology, HIV and TB space, clinical trials and research. Rutendo is a deputy program lead for WITS RHI, where they seek to advance HIV response to sex workers and transgender people in South Africa. She is committed to building an enabling environment for health and social services access for marginalized groups in our society. Rutendo is passionate about integrating health programs and operational research to document the best practices and lessons learned. Rutendo, could I please ask you to just show yourself before I introduce Tammy? And perhaps say hi.
Okay, my camera is acting up again, but hello, everybody.
Okay,
well, I hope I get it right. It looks like there's just a glitch on my laptop, and that's the settings that I had a problem initially. Yeah.
Okay. Okay, maybe whilst you sort of work on that, Rutendo, I will sort of move on and introduce Tammy. Maybe if you could mute your microphone, please. Our second speaker today is Dr. Tammy Nash. Tammy is a medical doctor who's worked with key populations in South Africa and abroad for over 7 years. Her main area of focus has been sexual and reproductive health within sex worker and transgender communities, but she has extended her interests and skills to include gender-affirming healthcare and harm reduction strategies. Tammy is a medical officer for WITS RHI and works closely with other health providers at WITS RHI sites in advanced clinical healthcare and gender-affirming healthcare. Tammy advocates for multidisciplinary model of health care provision and believes that healthcare should not just address disease, but rather support a person in a safe and holistic environment to achieve well-being in all aspects of their lives. So it is my pleasure today to introduce to everyone participating in this talk to these two speakers. I'm not sure if Rutendo has been able to get over the technical difficulties.
I've gone through my video settings and they're all fine, but I still don't have the feed. There's actually no light on my little camera on my laptop here, so I think this.
Tammy, oh, here you are. Say hi.
Hi everyone, evening. Thanks for having us. So, hi, I'm Tammy, and I look forward to some great discussion this evening.
Thank you so much. So I'm going to hand over to the two of you. I'm not sure who's going first in terms of your presentation. If Carol could please just share with you the ability to, so that you're able to share your screens. And then we will sit back and listen and engage with the material that you will
It's
be
automatic, Sakile, anyone can share.
Okay, thank you so much, Carol. So Rutendo and Tammy, over to you.
Thanks. So Ru's going to share. Thanks, Ru. So while this is, yeah, we can see it. Thanks. That's great, Ru. I just wanted to, we've said good evening and just thank the organizers for inviting us to kind of share our experience. Our presentation tonight will just cover a brief overview of where we came from, and our model will have a look at a little bit of data, the most recent data we have coming out of the sites, and then some of the challenges and lessons learned, and then hopefully have a sort of a Q&A, good discussion after that. So just kind of a disclaimer before we start is that neither of us claims to be experts in the fields of trans health, and we really just want to share the last 2.5 years, our experiences, and then hopefully, you know, it's always a learning process for all of us, and we're all learning all the time. So, you know, any insights and experiences other people may have on the call will be greatly appreciated, yeah, if we could all share. So thank you very much, and I'll hand over to Ru.
Thank you, Tammy. Evening, everybody. I'm really sorry about my video. Hopefully it will come on eventually. So Tammy has already given you the overview of what we want to talk about today. I'm really sorry if you can hear my daughter in the background. I hope it's not too distracting. I'm just going to share just a quick overview of our story as a program. So in terms of us as WITS RHI, I'm not going to go through all of the years here, but just to say that we are a USAID PEPFAR-funded program. We got an award to increase the HIV response for key populations, specifically for sex workers in transgender communities. And this was the first time in PEPFAR history that they actually awarded a transgender award specifically to an African country. So we felt extremely proud and, you know, up for the challenge in terms of being the first people to pioneer this PEPFAR award. And to date, we've got 4 clinics that you see in the next slide here. We have 4 sites across South Africa, here in Johannesburg, in Braamfontein. If those of you who know Joburg, it's close to the neighborhoods market in the Maboneng precinct. We've got one in East London, in Quigney. This site has also now moved to, we now have 2 sites there, one in Quigney and then another one at Duncan Village in East London. And then in Port Elizabeth, we are situated at a CHC in Port Elizabeth. And then in Cape Town, we are at the Belleville Shopping Centre. And we do work with other community partners and community-based organizations, and also the Department of Health. And on your right there, you see some of the community partners that we work with, Gender Dynamics and She. And we collaborate with other organizations through our Community Advisory Board, which is the CAB there. So we have a lot of interactions with Iranti, Be True to Me, and we'll talk about that later on in the presentation. So how do we work? We are very much a community-centered approach and a community-led approach, where we, as Sakile mentioned earlier on, you know, we really focus on the transgender individual as the person that's in the center, who's then surrounded by this multidisciplinary or interprofessional care. And we have this hub and spoke approach where we've got the clinic, which is a static clinic, as the hub. And then we've got the community outreach and community-based services that then act as the spokes, where we have the peer educators, we have the social workers, the nurses who go into the community and provide healthcare for the trans community. We endeavor to provide a comprehensive health service approach with these pillars that you see there around the psychosocial support, which is led by our social worker and psychologist in some of our clinics, and then the HIV services, which is the award that we have with our funders, PEPFAR and USAID, and then also just delivering a primary healthcare service around TB, STI screening, and also offering any family planning or adherence support where needed. And then obviously the biggest one is the gender affirming healthcare for the trans community. And at our clinics currently, we do offer hormone therapy, and we'll talk about some of the challenges of that later on, and some reproductive rights counseling. We do have referrals to other tertiary healthcare services and post-operative aftercare when required. And as I mentioned that, the model of care is really much around a client-centered approach where we endeavor to have an affirmative and participatory model of care and make sure that the gender or trans or gender diverse person is acknowledged as a key member of that team and of that gender affirming healthcare, and to make sure that they are driving their own healthcare and their own decisions around, specifically around hormone replacement therapy, but also around other conditions or any chronic conditions that they may present at the clinic. And this is who forms the multidisciplinary approach team, which can be interchanged with the interprofessional team. We have peer educators who are responsible for driving the community mobilization and demand creation in different spheres. We have an online outreach through our Facebook page, our Twitter page, and then also through the door-to-door campaigns that I'll show you later in some of the pictures that we have around that. And then the community health worker is responsible specifically on the HIV service side around HIV testing and counseling. And as the program has matured, we've also started looking at how we can task shift some of the functions and roles that we really had started in terms of building this proof of concept around delivering of gender affirming healthcare to primary healthcare setting. So we're finding that even some of our peers and our CHWs are starting to really understand the informed consent process. What does it mean to be on hormone replacement therapy? So they're starting to have that understanding, and sometimes in the community, they're the ones who are actually talking about it, but we still have the psychologists and the social workers, you can see, who are really driving that part. And then we've got the nurses and the doctors as well. And this is just a visualization of the site-based implementation team from the site manager who oversees all the activities of the site, and then the team that I've just been talking about, who then support that site around all of the care that is needed for the transgender community. And just to note there that, obviously in terms of the surgeons and the gynecologists, it's mostly the referrals that we do make, and they're not always successful, but we do endeavor to try and build relationships with gynecologists or surgeons in the hospitals in the districts that we work in, that we can actually refer people to. And in the last year, we have also introduced the social worker program. And this is really something that we are developing within the program that also looks at that task shifting, specifically around the informed consent process within the hormone replacement therapy program. And then here we've just included some of the scope of work for the medical officer, which I won't really go into detail with, but really just around rendering that comprehensive high quality clinical services. And they're also acting as the custodians of the clinical compliance within our sites. And in the mental health professional, usually the psychologist or social worker. At the moment, at all of our sites, we've got psychologist and a social worker that really driving the informed consent process and the gender affirming healthcare. And then what we're seeing, and Tammy will probably talk about this later as well, is that initially when we started the program, you know, the psychologist and the social worker were really brought in also around the hormone replacement therapy and all of that. But then we're seeing that outside of that, obviously there's a greater need for the psychosocial supports and psychosocial education within the transgender community. So that's something that we are continuously building and looking at, you know, what I was talking about in terms of task shifting. And then I think the cornerstone, or really the foundation of this multidisciplinary team, is actually our peer educators, who Sakile referred to earlier on as trans agents. And in the different sites, some of them prefer to be called trans agents, some of them prefer to be called peer educators. And these are really members of the community who are driving, as I said, the community mobilization, the demand creation, and also offering counseling and HIV testing through their social networks, and also mapping of what we call hotspots, which is usually either areas or clubs or taverns that transgender people are usually found or identified to be living in. And they're really the ones that are driving the program in terms of just that community mobilization and creating that demand for services. And I'll hand over to Tammy for the next slide.
Thanks, Rue. So I just wanted to kind of highlight some of the stories from our sites, some of the successes we've had through the multidisciplinary team. That has extended just beyond our gender affirming healthcare program. So one of the big successes we've had is around viral load suppression. There is a cohort of individuals around Nelson Mandela Bay who historically just never really virally suppressed for various different reasons. And what was really great is once the team was integrated and everyone was on board, they collaborated on the cases and addressed, you know, sort of barriers to adherence from a psychological, from a social point of view. I know, like, when they would go and get hormones, some of the medical officer would talk about sort of adherence in terms of antiretrovirals, not just around the HRT. And they would have these case discussions. And what we've seen is about a 12% increase at that particular site in viral load suppression, just through having this multidisciplinary team approach in a cohort that was really kind of refractory and we just weren't winning with. So that was great. And Ruth mentioned the HRT. It's been really interesting that the HRT has been sort of someone's point of entry into the service or the clinic. And what we have seen is once people are engaged, that the uptake of other services, so around the social and structural interventions, you know, as we know, people are more than just their sort of medical side, and we all have challenges, especially marginalized and stigmatized communities. So being able to then have that service and engage in it was really great to see that there was this about 2 to 3-fold increase, as well as the biopsychosocial intervention. So as part of our process of informed consent, there are psychology visits, and then what we found is after those, the people were then taking up the service because it was there, because it was available, and we were then able to kind of provide a more holistic approach to an individual and not just around the HRT. And then another great thing was the gender markers. We had a group of individuals who were sort of applying for their gender mark changes, and what was happening is, you know, the Home Affairs requires a letter from the psychologist and the doctor. So we provide that, but they were kind of getting stuck on the Home Affairs side, and the social worker became involved and developed a relationship. And then finally sort of that group, that initial group, all had their gender markers changed. So that was like a great success story just for the program. Next slide, please, Ruth. Thanks. So this is really just to kind of put actual figures to the program. We have spoken a lot around the MDT and what we're doing, but just from October to June, we've managed to engage and reach over 2,000 trans individuals, the majority of which have done an HIV test. So that number tested is referring to HIV testing. We've had some PrEP initiations, which is great, and as well as ART initiations, which have come out of those testing numbers. And then currently, as it stands to date, we have 360 trans individuals on HRT. Thanks, Drew. Next slide, please. So what this slide is, sorry, it says 354 there on the right-hand side for overall total. The slide was about 2 weeks prior to the most recent data. So that has increased just very slightly. But what we're really trying to show here is that from the numbers we can see is that 75% of individuals on the gender affirming program are using an integrated service, which is really important for us to be able to present and show. I mean, it makes perfect sense that you would want to get all your services at one place, but there's no sort of data. And if we're doing a proof of concept to look towards the future in terms of presentation and information around the data, this is so far looking really great as a strong argument for this this multidisciplinary team and integrated service. Thanks, Drew. Next slide, please. Oh, great. I'll hand back to Ruth. Thank you.
Thanks, Tammy. We wanted to just also, reflect and highlight that, the multidisciplinary team is not just the team or the clinical team that's working within the services, but also expands to working with other organizations that actually help to increase the uptake and to increase the knowledge within the community in terms of how they can actually utilize and access services. And we've just highlighted there's some of the organizations that form part of our CAB here in Johannesburg. And then there's another CAB in Port Elizabeth that also has some translate organizations and other organizations around the LGBTIQ spaces. And I think for us, in terms of that, just how we look at this multidisciplinary team, not just as a siloed approach, but also, that expands outside of the clinic and looks at how we then interact with the rest of the community and understand the community needs and make sure that we're tailoring the services that we're providing to the community, and also bringing in and also just maybe keeping us on our toes and making sure that, the services that we are promising, we are delivering. And this is just one of our meetings with community representatives, just to show that link between the multidisciplinary team within our program and within our clinics, and how that then links within the community, and how we then interact that MDT team with the community representatives. And we usually host meetings every 4 to 6 weeks, where we are sharing, the data that we've got from the previous month, some successes, some challenges, anything that, pertains to the community. And then in turn, this community advisory board, as the word suggests, that, there's also that advisory role in terms of, the services that we should be providing in terms of what the community is saying. So, they are also the voice of the community that are giving us that opportunity and that information and that knowledge for us in terms of how we carry on with our services. So we just wanted to show this, that, as much as we're talking about the multidisciplinary team within the clinic space, that, that kind of overspills into the community as well. And then this is just to show in terms of, how we optimize service accessibility. We find that within the 4 sites that we are operating in, 72% of all of our tests and 89% of all of our ART initiations are actually done within the community. So, transgender people are not necessarily coming into the clinic. This is where I spoke about that hub and spoke model, where we have, yes, the clinic is there, but we find that, and this is not news to anyone who's on this panel, but just the historic stigma and discrimination that the transgender community has faced, usually when they want to access care. They've really shied away from, going into the clinics and all of that. So we're still finding that within this program, most of our work is actually being done in the communities, and also just some people who still haven't quite come out as transgender people, but then they do ask for our services. And this is also an opportunity for us to meet with those people who are not necessarily wanting to come out into the community or be seen coming into the clinics. And I'll just speak briefly around challenges, and we've decided to narrow down the challenges specifically around the multidisciplinary approach. But, we still have some time, and we can obviously speak more around just the challenges of the program as a whole. But I think, one of the things that we face in terms of the multidisciplinary approach is that just the dearth of professionals who are actually skilled in gender-affirming healthcare that we can actually bring into the team. And every time we do have a new professional that's starting, that time that it takes to build that interface and referral between the different cadres, and for people to be comfortable and to ensure that and guarantee that smooth functioning of the multidisciplinary team again. And just also, I think, and this is from a program perspective, just that transgender representation within the multidisciplinary team, especially at a more senior level. As I mentioned earlier, if you saw most of my pictures, the peer educators are usually the transgender people, and as you get to the nurses, to the doctors, to the social workers, then that transgender representation is quite lacking. And then just also around the, as I mentioned earlier on, we work very closely with the Department of Health, and the agreement between the Department of Health and PEPFAR is that, PEPFAR provides the equipment and the human resources, and the Department of Health then provides the medication and commodities. And just trying to get that buy-in of a multidisciplinary team at a primary healthcare level within the Department of Health sometimes can prove to be quite challenging. And then also just around the donor requirements. I mean, Tammy showed you just a small slice of the HIV cascade, and that's really the mandate of the donor in terms of, what services we need to be delivering. But as Tammy said, a transgender person is not just about HIV. So how we then interface and integrate the rest of this holistic and complementary services approach, and still make sure that we are meeting the donor requirements around the targets and the indicators that are set for us. And this is just another picture to show some of the challenges around, the multidisciplinary team. This is actually where we work most of the time when I talk about door-to-door. And we find that sometimes within that multidisciplinary team, some of the professionals are not really used to this kind of work. And, people go to outreach, for example, in this kind of spaces, and it really takes them out of their comfort zone. And it's very difficult for them to kind of understand and to go back to these kind of settings. And then we end up with either resignations or people being really unhappy, and then having to then look for somebody else. And then that goes back to what I was saying about, trying to find professionals who are actually skilled and qualified to offer gender-affirming healthcare within the space that we're working in. And I think I'll just hand over to Tammy to just go through the lesson.
Thanks, Rue. So this is just a brief sort of reflection on some of the lessons we've learned up to date. One of them being it's really important to have ongoing community engagement. Obviously, at the start of the program, that was part of it, but Rue's mentioned the CAB and as well as the rest of the community to, not to just kind of assume that we know and carry on with what we think is best. So to have that ongoing engagement. Also, Rue has mentioned as part of the challenge, the engagement with our National Department of Health. So that's been really important to keep that ongoing. Another thing that we've learned is, you know, in terms of our messaging, be it on our social media or the information that peers may give to individuals, is it is important to be accurate around what services we do provide and what services we don't provide, so that we don't, you know, meet or don't meet expectations. And with that comes, you know, really important to have this good communication and updating of clients, you know, in terms of any changes within our services, any perhaps challenges we're having that may affect the service. Another thing that's been really important for us to learn is around this group work and support. And, you know, there's a lot of evidence, and we do know from our own clients how isolated and lonely people can be, and you know, distance from families. And what the sort of hope is, and what we've seen is, you know, if we can bring a group together for whatever reason, be it, and we've mentioned down there sort of these groups around informed consent, but it also creates a sense of community. And we've seen clients who have really felt isolated then start to engage with members of the community through group work at the sites. Really important is this ongoing client case conferencing. And what we mean by that is, so our sessional staff may not work on the same day, they may not work the same hours. So it's really important that there is this continuous communication between the different members of the multidisciplinary team for updates, and also, you know, for the best client outcomes. And then around the informed consent process, Chris, you've spoken about this before as well. You know, in terms of language, there's a lot of information we impart around informed consent, and perhaps, you know, it is in English, and it may not be someone's first language or mother tongue, or, you know. So what's been really great is if we can start the process in a group setting, and it also gives people time, you know, before they sort of access the service. We can do it beforehand, and then questions may come up. There may be more complicated things, for example, like side effects or complications from the medication, you know, that people may not be familiar with. And this gives, you know, someone an opportunity to perhaps think about, perhaps have their questions answered, instead of sort of sitting in front of the doctor or the psychologist and saying, yes, I'd like the hormones. So that's been a really great way to kind of start the process, to give someone a sense of community and to address any questions that may come up. And then aside from the HRT, to also have these, we call them creative spaces, and that's just around health promotion in general, not necessarily around the HRT, but health, you know, well-being, general well-being, good health practices, because, you know, as Ru and I both mentioned, this sort of holistic kind of approach, and that someone is more than just the sum of, say, an illness presenting. So those are really sort of great opportunities to engage with people from a community and also get a message out there. Thanks, Ru. I think that's the last slide, if I'm correct. Yeah. So we'll stop there. Just thanks everyone for listening. And Sakili, I think we'll hand back to you for the next part of this. Thank you.
Thank you so much. Thank you so much to our presenters. Wow, it's really, really interesting work that you've been doing, and just looking at the numbers in terms of how many people you've been able to reach that otherwise would have had difficulties in accessing the services. For me, that is what it comes down to.